Hello, my presentation today is going to be on gastric duplication cyst, presented by me, Kylie Hubler. Context of the case. Gastric duplication cyst is a very rare congenital anomaly accounting up to 4% of all gastrointestinal tract duplications. It is a quite rare anomaly in adults. The majority of cases are diagnosed in the neonatal period. Gastric duplication cysts are usually asymptomatic, or they do present with nonspecific symptoms. They are usually discovered incidentally during endoscopy or laparotomy, or very rarely after getting complicated. Location and structure. GEDCs are typically located along the greater or lesser curvature of the stomach, but it can occur anywhere within the stomach wall. They are often single, cystic, and lined by mucosa, similar to the stomach, although the cyst lining may vary, such as glandular, gastric, or intestinal mucosa. Etiology. The cause of GEDCs is usually congenital, resulting from abnormal embryological development of the gastrointestinal tract. This may involve the failure of normal recanalization of the foregut during early fetal development, leading to a duplication of a segment of the stomach wall. Clinical presentation. Asymptomatic cases. Many GDCs are asymptomatic and are discovered incidentally during imaging studies or surgeries done for unrelated reasons. Symptoms. When symptoms do occur, they are often nonspecific and may include abdominal pain, vomiting, bloating, gastrointestinal bleeding, anemia due to chronic blood loss, or more rarely, perforation or infection of the cyst. In more severe cases, especially if the cyst becomes complicated, such as internal bleeding, perforation, or infection, the symptoms can be more acute and lead to significant clinical distress. Diagnosis. Endoscopy. A gastric duplication cyst may be detected incidentally during an upper gastrointestinal endoscopy when investigating unexplained symptoms. Imaging. Techniques like ultrasound, CT scan, or MRI may be used to identify the cyst and assess its size and relationship to surrounding structures. Histology. Definitive diagnosis is usually made by surgical resection followed by histopathological examination, which reveals the cyst characteristic features such as the presence of gastric mucosa. Complications. Internal bleeding. One of the significant complications of gastric duplication cyst is bleeding, which may result from ulceration or trauma to the cyst. Infection. Infection within the cyst can lead to abscess formation. Perforation. In rare cases, the cyst may perforate, leading to an emergency surgical situation. Malignant transformation. While very rare, there is a potential for malignancy, particularly if the cyst is not detected early and becomes chronically inflamed. Management. Surgical excision is the mainstay of treatment, and this is typically performed once the cyst is diagnosed or complications arise. The type of surgery depends on the cyst location, size, and associated complications. If the cyst is asymptomatic, conservative management of regular follow-up may be appropriate, though this depends on the specific case. Duplication cysts can affect digestion by causing intestinal obstruction, abdominal pain, nausea, vomiting, and sometimes bleeding due to their mass effect on the surrounding gastrointestinal tract, essentially blocking the normal passage of food through the digestive system. The severity of symptoms depends on the size and location of the cyst, with larger cysts causing more significant disruption to digestion. Article summary. The case study describes an adult patient who presented with abdominal pain and bloody vomiting, signs suggesting gastrointestinal bleeding. The patient was initially misdiagnosed with more common gastrointestinal conditions. After a thorough investigation, including imaging and endoscopy, the cyst was discovered. It was complicated by internal bleeding, which was a significant factor in the patient's clinical presentation. The patient first took antibiotics and then underwent surgery for the excision of the gastric duplication cyst. Post-surgical recovery was uneventful, and the patient's symptoms resolved. Case study presentation. A 28-year-old female patient presented to the emergency department complaining of 3 days' history of exasperating epigastric pain, irradiating to the back and not relieved by over-the-counter medications. The pain was associated with nausea and episodic vomiting containing streaks of blood. She denied any history of fever, fatigue, or changes in bowel habits. No urinary or respiratory symptoms as well. The physical examination was unremarkable except for mild discomfort at the epigastric area upon deep palpitation. Basic laboratory investigation showed normal hematocrit level and normal white count. The pancreatic and liver panels were within normal ranges. Initial workup in the emergency room was done with an ultrasound showing a bilobulated cystic mass in the right upper quadrant measuring approximately 15 by 6 centimeters, having smooth internal surface with dependent ecogenic component. Further investigations with a contrast-injected CT scan showed a bilobulated cystic mass with thickened enhancing wall, smooth inner border, and dense content. An endoscopic ultrasound was then performed, showing a multi-layered lesion containing echogenic content with some of its layers continuous with those of the gastric wall. Features are highly suggestive of gastric duplication cyst. The content of the cyst was aspirated, yielding serous fluid and explaining the streaks of blood described by the patient. FNA needle biopsy performed at the same time during the endoscopic ultrasound showed numerous polynuclear neutrophils, macrophages, and numerous red blood cells. No malignant cell was detected. Upper gastrointestinal gastrographin swallow was also performed to assess the presence of communication between the stomach and the cystic lesion. It shows early contrast filling of the cystic lesion as the contrast arrives to the stomach before reaching the duodenum. The top left picture is an image of a transabdominal ultrasound. The bottom right is an axial contrast enhanced CT scan, and the bottom left is an image of the endoscopic ultrasound. The image on the left is the anteroposterior radiograph of an upper gastrointestinal gastrographin swallow, and the image on the right shows the microscopic pathological analysis of the surgical specimen after resection of the gastric duplication cyst. 1 month prior to presentation, the patient started complaining of early satiety and epigastric discomfort with reported weight loss estimated around 7.5 kilograms over the last month. The patient was hemodynamically stable with significant improvement of her symptoms on medical treatment. She was started on antibiotics because of the inflammatory pattern of the lesion on the CT scan and the dominance of the polymorphonuclear neutrophils on the FNA. The patient was also discharged home after resolution of her symptoms, to be followed clinically and radiologically. Elective surgical incision of the lesion was planned after the resolution of the inflammation or earlier in case of recurrence of the symptoms. 1 year after, the patient presented again with recurrent similar symptoms including abdominal pain, intermittent vomiting, and streaks of blood. Laparoscopic excision of the cyst was performed successfully with no post-operative complications. The lesion showed an identical wall as the gastric wall. It was found adhering to the graded curvature of the stomach at the inferior antral and pyloric border with no clear separation. Pathological analysis of the lesion confirmed the diagnosis of gastric duplication cyst, showing the multi-layered aspect of the wall similar and continuous with the mucosa and submucosa layers of the gastric wall at the surgical margin. The patient did well after the surgery. She denied any recurrent symptoms on her outpatient follow-up visit 3 months after discharge. Case presentation. The patient, an adult, presented with abdominal pain and bloody vomiting, which are concerning symptoms suggestive of gastrointestinal bleeding. These symptoms are nonspecific, and in many cases they can be attributed to common GI conditions like peptic ulcers, gastritis, or even malignancy. However, in this case, the patient's symptoms were ultimately traced to a gastric duplication cyst, a rare congenital anomaly that is most often diagnosed in neonates rather than adults. The patient's presentation with bloody vomiting was a significant complication of the gastric duplication cyst, pointing to an internal hemorrhage. This complication is not typical for GDCs, as most cases remain asymptomatic or present with nonspecific GI complaints such as abdominal discomfort or bloating. This discrepancy between the usual symptomology of gastric duplication cysts and the patient's acute symptoms is noteworthy and highlights the uncommon nature of both the disease and its presentation. Management. Given the complications, internal bleeding, the treatment involves surgical excision of the gastric duplication cyst, which is a standard approach once a complication is identified or the cyst causes significant symptoms. Surgery was necessary due to the risk of further bleeding, infection, or potential perforation. all serious complications of GDCs. In the case discussed, the cyst is likely located in the stomach wall, as most gastric duplication cysts are, and removal would have been essential to both stop the bleeding and prevent further complications. The decision for surgery seems appropriate in this context, considering the patient was experiencing significant GI distress and bleeding, which likely would have not resolved without intervention. It's important to note that surgical excision is often curative, and patients tend to recover well post-operatively once the cyst is removed, as seen in this case. The outcome was favorable as the patient recovered without further complications post-surgery. This aligns with the expected course for most cases of gastric duplication cysts when appropriately managed. Since the cyst was excised and the source of bleeding was removed, the patient's symptoms resolved. The image at the bottom shows a laparoscopic excision of a gastric duplication cyst. Correlations. Clinical presentation and diagnosis. The initial symptoms of abdominal pain and bloody vomiting are clearly linked to the gastric duplication cyst complication of internal bleeding. The patient's presentation of bleeding, though rare, is in line with what can happen when a cyst undergoes ulceration or trauma. The diagnosis would have been confirmed with endoscopy or imaging, making the detection of the cyst a natural consequence of investigating the unexplained GI bleeding. Surgical management and outcome. The correlation between the discovery of this gastric duplication cyst and the subsequent surgical excision is direct. Surgical excision remains a gold standard treatment for symptomatic or complicated GCDs as it removes the source of bleeding and prevents reoccurrence of complications. The favorable outcome post-surgery aligns with the expected results for most patients after surgical removal of such cysts. Possible inconsistencies or surprises. Age of presentation. The most notable inconsistency is the adult age of presentation. Gastric duplication cysts are almost exclusively diagnosed in neonates or children, with only a few cases reported in adults. In this case, the cyst was identified in an adult, which is unusual since adults typically present with cysts that have been present for years without causing significant symptoms until complications occur. Complicated presentation. The cyst complication in the form of internal bleeding is another uncommon aspect. Gastric duplication cysts are generally asymptomatic or may cause vague, nonspecific symptoms. The presence of bloody vomiting as a primary presenting symptom is atypical. While bleeding is not a known complication, it's rare for it to be the initial presentation. Most cysts are asymptomatic unless there is ulceration, infection, or in rare cases, malignancy. The fact that this patient presented with a complication rather than with a more classical presentation of an incidental or nonspecific abdominal complaint is notable. Independent analysis. While gastric duplication cysts are more common in neonates, the rare adult presentation challenges our typical understanding of this anomaly. In adults, the cysts remain undetected for many years as it does not produce symptoms unless it becomes complicated by ulceration, bleeding, or infection. These cysts are lined by gastric or intestinal mucosa and can become prone to ulceration, leading to symptoms like bleeding or perforation. This patient's internal bleeding was likely a result of such a complication. Given that GDCs can cause a range of nonspecific symptoms, including nausea, vomiting, and pain, it's crucial for clinicians to have a high index of suspicion when evaluating adult patients with unexplained GI symptoms, especially when there are signs of bleeding. Though rare, gastric duplication cysts should be considered in differential diagnosis, even in adult patients, especially when common diagnoses don't fully explain the clinical picture. Delayed diagnosis and surgery can lead to complications including volvulus, intussusception, recurrent hemorrhage, and risk of malignant degeneration. These are my references. Thank you so much for listening.